Claire, you are helping me change, so could you go to the second slide? Yeah, let me first introduce Rays of Hope Hospice Jinja. Rays of Hope is an interfaith a non-government organization. We were originally started in 2005 and working in Busoga region. Originally, it was more closer to Jinja, but now we are spread over throughout the region. Our vision is palliative care for all in Busoga region and beyond. And our mission is to provide palliative care and improve the quality of life for everybody with people with life-limiting diseases and their families, importantly, for those who live in Busoga region and beyond. All right, the next, we go into look a little bit some background information. You can see, like in the last year, 2021, we had a total of 1,071 enrolled patients. That is throughout the year. On an average, last year we had 549 patients on program. I can tell you this year we have had a big influx of new patients, which is lovely because they need help. So we are way over 600 patients enrolled per month. Of those, 2/3 are women and little over 10% are children. The diseases we are dealing with is for the vast majority cancer, 58.5%. And then we have also HIV/AIDS, but that's severe HIV/AIDS, 13%, and those who have both cancer and HIV is 8%. The other 6 patients are other diseases. That could be osteomyelitis, it could be tropical sores, ascites, etc. What is interesting, if you look at the last 6 years since 2016, you will see that we have had a steady increase in new patients. And this is our aim, to reach those in need. So it has almost doubled over the last years, and also the number of patients served. I will tell you though that when we get new patients to this day, still we get patients very often and way too often, patients who are very, very sick, and where we ask ourselves, where were they, where were we, how come we have not met before? So this is our really our wish, to get out there to find people, and we find them in the huts in the way back in the deep in the village. And anybody here from Busoga region who can help us in this effort, we would very much like to work closer with you. Of patient contacts, that's been, just wait a second, Claire, I'll tell you, go back again. Thank you. Patient contacts, we had a little over 6,000 patients in 2021. You could see that in 2020, we were slightly more. We have had some issues around COVID, but still managed to continue our work even during the epidemic and when there was transport problem. Okay, thank you. The next one. Yeah, you probably all know the goal for United Nations for Sustainable Development for 2030. The goal is somewhat simple. It is that all people have access to the health services they need, when and where they need it, and without financial hardship. And next one, Claire. The present reality is unfortunately not that one that we see in Busoga region, because in very many areas in the rural parts, we see little or no access to needed health care. And you will see that there was a report done by the Landsat Commission in 2017, and they actually start with this very strong statement that I will read to you, because it describes our situation, unfortunately, so very well. Poor people in all parts of the world live and die with little or no palliative care or pain relief. Staring into this access abyss, one sees the depths of extreme suffering in the cruel face of poverty and inequity. And that is what we see, unfortunately, so many times when we go out. This is what we are looking into, the access abyss, that big dark hole of no access. So when we are building up our program, we have to deal with that reality. And the next one, Claire. And what are the obstacles on the road to good health? We have looked from our experience in Busoga. You can see there's people coming in from Kuku, and I'm sure you have, and all businesses, I'm sure you have very similar experiences. But for us, what we looked, there's very long distance to primary, long to go. There's very few hospitals or specialized treatment facilities. As we know, for cancer, Uganda cancer is Kampala, and it's far from Busoga to Kampala. Limited drug supply is also an issue. Then, unfortunately, limited knowledge at the health units, failure to find out that diagnose cancer in the early stages, and it takes very long before they actually come forward. And also limited knowledge in the community among the population. And then what I have written, something that sounds nice, limited finances, but the reality would be poverty. That's a serious obstacle on the road to healthcare. So Claire, next one, please. So we are trying in our program to build up so we address those obstacles. First of all, we do home-based care. We help you where you are. Why do we do that? One thing is that otherwise nobody would reach us. Transport is expensive, but also people are sick and they can't move. So we have to go to them and we do that. The advantage with this is also you see where people are coming from. You understand their family situation, their social situation much better. Then for you had limited medication, we treat the pain and the symptoms related to the disease. On this picture, you can see she's smiling happily. You cannot, and you can see the bottle of morphine on the side. Covered up is like a huge wound on the top of her right side that is like 2 of my hands that big. And the caregiver is behind, but they can smile because the symptoms are taken, the pains are taken. Now, we have done a lot about training health workers. A couple of years ago, we sat down and said, what is it that we would love the health workers to know in order to deal with cancer better, and what don't they know? And so we developed a 3-day course, that we are giving. I think it's about 350 health workers throughout Busoga region. And the wonderful part is that the health workers are very interested and it's improved. We went up for referral from health units from, I think, 18% of referrals before we start the courses to now a little over 1/3 of all our referrals comes directly from the health units. Our patients are poor, as I said, psychosocial support, food if you need it, counseling always. And Claire, if you take the next one. Claire, can you take the, yeah. And then what we're going to talk a bit more about today is also prevention, because we see people come so very, very sick, and some of our patients can be treated, particularly cervical, can be prevented. And we are going to talk that in detail under the cervical cancer. And then finally, treatment is an important part of our program. People are poor, and many are too poor to go to Kampala to get the test, to get the treatment. And we feel it's a human right for every person on this earth to get the treatment that they need. A picture is of one of our lovely patients who has severe AIDS with Kaposi sarcoma, as you can see, and she got totally healed, fine. She's a mother of 2, an important person, and she now has a little piggery and is taking care of the children and also inspiring others in the community to come forward with it. Claire, can you say it's good? Now, today's subject, what we are going to do mostly about is cervical and breast cancer. So just a bit of background information first. Cervical cancer is the most common cause of cancers in Uganda. 1/5 of all new diagnosed cancers at the Cancer Institute is cervical cancer. And this is about the whole group of cancers, but for women, it is a little over 1/3 of all cancers. And 22% of all cancer deaths. A huge number. Breast cancer is the 3rd most common cancer in Uganda. I think many will ask what is the second, and if you do that, I can tell you it's Kaposi sarcoma. But breast cancer is the third most common. And an interesting little piece of information is that here in Uganda, the survival rate is 50%, 5-year survival rate, meaning that if you, after diagnosis, you go 5 years forward, are you still alive? In Uganda, it would be 50% of the cases. Now, in a country like United States, it is 90% of the cases. And that is pretty, the treatment we have here in Uganda, we have doctors who know it, but it's a question of access, that people come in time to benefit from the treatment. And then I just want to give a little picture of what we are dealing with here in Rays of Hope. Last year, of all the patients we had enrolled, 150 women of those were enrolled with cervical cancer. Of these, 86% were HIV negative, and 14% was HIV positive. There's a little higher percentage of HIV positive because if you have HIV positive, you're more prone to get cervical cancer. Clear? So if you go on to the next. Yeah. So we took a little picture in October last year, just 1 month, to look at what is the distribution of our patients and the diseases that they're diagnosed with. So we had a total of 373 women on program. That could be both HIV, could be cancer, anything. And of those, 78% had cancer. Of these with cancer, 42% has cervical cancer. So it's almost half of our women with cancer has cervical cancer. And of these, 13% had also HIV/AIDS. Now for breast cancer, 15% of our patients, women patients with cancer, had breast cancer. So if you add them together, it basically means that 57%, almost 2/3 of all women with cancer enrolled, has either breast or cervical cancer. And if you go on, Claire, please. I will go, so could you go back again? I was a little too fast. Yeah, so basically what we had was sitting down to say, listen, we cannot sit and wait as a palliative care program to wait to see that these patients are come very sick. The woman on the top was a beautiful, beautiful young woman. She was 28 years old and she had HIV/AIDS and cervical cancer. And this is how we found her, in a corner of a hut, totally isolated, with this cervical cancer, in my opinion, is a disease of the devil. With a discharge, with a pain, with a smell, and weight loss, it's a horrible disease. So we have to go out and find out how we can get them earlier, because honestly, it's unethical to wait for them to come to us. So if you take the next now, Claire. Clear, okay, fine. So we looked at what are the challenges that are facing these women. How come that it takes so long? And again, there were certain areas that was struck. Little knowledge about cervical cancer in the communities. Little knowledge about cervical cancer among the health workers. Many are treated again and again and again for pelvic infection when they come with signs and symptoms of cervical cancer. Limited cervical cancer screening services in Busoga region. Very, very few. If you have the systems, you basically have to come to Jinja. So all this leads up to late diagnosis of cervical cancer. And once you then diagnose, there's limited access and it's costly to go for a cervical cancer treatment. These are the challenges that the women are facing, and which means that they end up in corner of the heart with smell and discharge and all the problems of cervical cancer. Please, the next one, Claire. So one of the challenges for community education. We are out in the villages, we're working with community volunteers, and here's one of our nurses giving education to the women collected for cervical cancer screening. And the women are really interested. It's wonderful to see. Then we do on-site screen and treat programs for cervical cancer, and we checked manually for breast cancer at the same time. I want to dwell a little bit with this picture because that is a picture taken in May 2019 in Banda at Banda Health Center in Namayengo. And everybody has basically told us we cannot go and give screening to rural women. They don't want to have the screening, they don't want the pelvic exam. And basically at that time, we said, listen, we are seeing so many very sick women coming forward with advanced cervical cancer, we would have to check it out. So we did a camp for 4 days in Banda Namayengo, and we had a total of 700 women. You can see of the amount of women collected. We worked from 7:30 in the morning to 7:30 at night. I think we were all very tired when we were finished, but also very happy because women are interested. And my personal opinion is they're very interested because they all know somebody who has had it, or a sister, a neighbor, or what, and they don't want to have the same. So we do on-site screen and treat programs in collaboration always with the government health centers. Yeah, next one. So of course, when we go out and do camps, that is like we go and then we are gone. The ideal thing and the best thing is, of course, to establish screening sites in government facilities. And in 2021, we worked with Jinja Health Center 4 in Namayengo and at Banda Health Center 3, where we had training of the staff there and helped them establish with both the equipment that they need and also with follow-up supervision and collaboration for a year, and they are now self-running. This year, we have worked with Busoga Health Center 3 and Kira Health Center 4 in Jinja district, and doing exact same thing. So there is ongoing screening continuously and not only like in camps. We are in progress. We had a big training with a camp and a big training camp in Buyende, in Bukungu, which is like a health center way out at the lake. And they are now in the process of getting established. We have actually found that following the USAID programs, there has been a lot of training going around. Many places they are only screening the HIV positive women, which I find is a problem. As I shared with you, we had 86% of our cervical cancer cases were HIV negative. But anyway, some screening is going on. Sometimes we have found that they're reluctant to treat on the site, not being so familiar with the thermocoagulator, and we are very happy to help if that's the case in any of you. Okay, so the other challenge is the costly treatment. Once you are diagnosed, what do you do? So the challenge is how do we go and get the treatment we need? And for all our screening activities done, the ladies who are showing that they have precancerous cells will be treated on site, which is very convenient with a certain coagulation. But there are also those who will need to have a biopsy or will need to get further training and evaluation at UCI and treatment. So we have started way back in 2016. We started a treatment program basically on what we said before, human rights issue, to human right to get treated. And you can see there's been a steady increase in numbers supported with treatment costs. It could be including transport of food, and if needed, sharing of the treatment costs, testing costs, if needed, full pay. If that is needed, we talk with the patients, we know them, we know their homes. So last year, we had a total of 176 patients that were supported with treatment. And of these, 39 had cervical cancer and 22 had breast cancer. And you will see like the average support for treatment given was about a little over 700,000 shilling, which in my opinion is not a huge amount for a life, because it is mothers, fathers, children that you can get through treatment, and they deserve it. You can take the next, Claire, please. So what came out of all our attempts to try and make it easier to access preventive examination and treatment for cervical cancer and avoid the many very advanced cervical cancers that we are seeing and that we are still seeing? There's many more out there. So we started in 2018 and up until June 2022, we have screened a total of a little over 4,500 women for cervical cancer. Of these, 328 women, which is 7.2%, were either VIA positive, they were treated on site, or cancer suspect, they were helped with further examination and treatment. Just go back and say, I'm sorry. Yeah, thank you. You will see this year it's going really well. It has helped. The COVID is no longer there. And so the last for 2022 was only for 6 months. And the uptake is getting higher and higher, which we are very, very happy for. But COVID was a challenge. Yeah, next one, Claire. Now, if we look at cervical cancer, this is a disease that can be prevented and controlled. And that's why it is almost criminal that we have so many severe cervical cancer cases. The primary prevention is the Hpv vaccination, which has started in Uganda. I think that when COVID came, it became a challenge, and I think that it's gone a bit slow, but the Hpv vaccine, as I understand it, is available. This is the primary, preventing the HPV to come, because HPV is the cause of about 96% of all cervical cancer cases. The secondary prevention is the screening. This is that you go in and you look for the precancer cell and treat them before it develops into cancer. And that one you do from about 25 years and forward. The tertiary prevention is all the women who have cancer already, that you help them with getting the treatment that they need. It could be surgery, radiotherapy, chemotherapy, or palliative care if there's nothing else to do. Okay, next one, Claire. And as I said, cervical cancer can be prevented. There is a very interesting article that was written a couple of years ago, where they describe seen from the northern countries, cervical cancer is a disease of the past, whereas in the southern countries, particularly Africa, cervical cancer is a disease of the poor. And they have basically in the northern and the more highly developed country have basically eradicated or brought cervical cancer down very, very low. And how have they done it? They have had prevention, they have had their pap smears, and they have treated whoever was there. So it is very low, the mortality. Actually, Australia is planning or expecting that they have eradicated totally cervical by 2030. Now, you can find Uganda here, and unfortunately, you can see we are in the dark area because I think so, can we take the next one, Claire? So actually, WHO, knowing that picture all way too well, they have made a global strategy to accelerate the elimination of cervical cancer. And they have set up a 90 targets to be reached by 2030. And basically, friends, we are all part of reaching these targets. The targets goes on 90% of girls fully vaccinated with HPV before age of 15, that 70% of women are screened with a high performance test by age 35 or again 10 years later. And then that 90% of women identified with cervical cancer receive treatment. Now, I think looking at those numbers, we all know that we have a long way to go, and we have 8 years to do it in. I think overall now it's about 5 to 10% of women who have ever been screened. There are many, many percentages to go, and we have to be busy and get our focus on it. Okay, next one, please, Claire. We have the Hpv vaccination, which is a very good vaccine. Very important information came in April this year. You probably know that until now, Hpv has been given on a 2-dose schedule. For, I think in Uganda, here it's girls of 10 years old. 2-dose schedules are always difficult because you have to give it and then you have to find them again, the same people. But they have actually updated their recommendations, the strategic advisory group of experts for WHO in immunization. And actually, they say you can get away with 1 dose only, which would be huge. It has to be accepted by the countries individually, but that is the recommendations that came from WHO a few months ago. I think here we go mainly for the children. I don't think we are talking about young women yet, but you can see the information there now. And then for immunocompromised individuals, particularly those with HIV/AIDS, if at all possible, they should have 3 doses. Why? Because the Hpv vaccine gets much better possibility to develop cancer in immunosuppressed. Yeah, next one, yeah. So we know that here in Uganda and many other places, we are using the VIA test, visual inspection with acetic acid. But actually, WHO is now encouraging countries to use the Hpv test for cervical screening. Why? Because it is a much more reliable test. It's objective. It's either positive or negative. Those of you who have been doing a VIA test will know that there is some interpretation done. If I'm good at it, I will catch everybody. If I don't know so much what I'm doing, I may miss some. So it's much more subjective. Also, what is really a wonderful thing is that if you use the Hpv test, you can do, I think many places they use it almost like you're putting a tampon in, and an hour later you can read if you're HIV positive or negative. HPV positive or negative. So those who are HPV negative will not have to go through the vaginal exam. Now imagine so many few women you actually have to do the vaginal exam on. That takes time. So you can get through more, excuse me, in a shorter period of time. So this is something we are hoping for. It's still fairly expensive. The test, last I heard it, was about $6 per woman. But really a lot of research and development is going on in this area. And I think we'll see that in a very short time. Claire, will you take the next one? And one thing that they're right in this guidelines in the strategy for elimination of cervical cancer is that screening must be linked to treatment and management of positive screening tests. And I think that's very crucial. Basically, it's common sense. Why would I go and get screened if I'm only told that I'm positive and there's nothing to do? So it is both the treatment on site, you can do with thermocoagulation, it's easy if you have the equipment, and also follow up if you have more than just pre-cancer cells, where you actually have suspected of cervical cancer or even advanced cancer. But it must be linked. And that is something about making the treatment affordable, basically along the lines of the Health for All goals, where access to health when you need it, where you need it, and for an affordable price. Oh, yeah, will you take the next one? Thank you. So where are we? We talked to you a little bit about what we see here in Busoga, but if you look in Africa, where are we and where do we need to be? So the cumulative incidence for cervical cancer in Sub-Saharan Africa, cumulative incidence means like in a whole life of, for all women, their whole life added up. For Uganda, unfortunately, is number 6. Number 6 in the number with the most cases, highest cumulative incidence in Sub-Saharan Africa, where we can expect that 1 out of 18 women will get cervical cancer in their lifetime. That is high. So I haven't seen the list here. I think it might be probably about 18 women, perhaps even more. One of us will get cervical cancer in our lifetime. The most highest incidence of cervical cancer is in Tanzania, followed by Zimbabwe, Kingdom of Eswatini, Zambia, Mozambique, and Louis Reunion and Nigeria. I was a little surprised myself to see Nigeria. I was thinking it's Nigeria, but it's surprising. But we are unfortunately high up there. We have a lot to do. And then, Claire again, can you forward? So also just to put it in perspective, what we are doing, what we are talking about here in Rays of Hope Hospice Jinja, last year in 2071, we lost 71 women who died of cervical cancer. These are mothers, their sisters, their daughters, and they come, many of them in the age group where they are of motherhood. It is sad, and they are dying from a disease which is both preventable and easily treatable if diagnosed early. It should not happen, basically. So we cannot just sit and mourn and worry. We are trying to see how we can fight against women's cancer. One thing that is crucial is the awareness raising. And I will share with you a little bit the Rays of Hope Hospice Jinja have in the last since 2019, we have had 3 campaigns in the fight against women's cancer. We include breast cancer as well. And basically awareness raising. And we started in 2019, fight women's cancer. We run, we bicycle, we walk for cancer. We are out talking to communities. This year we will have films as well about cervical cancer. And basically raise the awareness that it's a problem. I'm actually personally very happy this year, and I'm sure Sylvia will be, that before when we started in 2019, we said go get screened, but the question was where. That was not. Actually now we are starting to have places where you can go and get the screen, which is so important. And together we can do a lot. This is from last year's campaign and walk. And we are just, nobody can do this alone. You saw the goals, you see how far we are in reaching them. We need to work together. But in some ways, it's also a fantastic opportunity for us, I think, of being partners in trying to eliminate the horrendous disease of cervical cancer. So I hope that we can get together and we can stay together and fight this disease. Claire, next one. So these are just the flyer for Fight Women's Cancer. We start the activities on the 1st of October, but the final big thing will be on the 29th, Saturday, at the Jinja Golf Club. We will start, and then we will have a big walk, run, ride around town. We are painting Jinja pink, and please come and help us. If you are living elsewhere in Busoga region, we will also have activities in certain areas. If you are interested, please contact us, and we will be very, very happy to work with you. Okay, and then the last one, this is just our contacts. Perhaps you can give it a little bit so that you just get the main contacts, but otherwise I'm sure Claire can give it to you later. Thank you so much.